Welcome back guys. Now let's discuss about the clinical cases which you need to know regarding the topic of pituitary gland. See, in the first clinical case, here you can see there is damage to the pituitary stalk. So you know here is the hypothalamus, and what exactly is this guys? This is the pituitary stalk. Now because of some reason, maybe because of a road traffic accident, what if this pituitary stalk gets separated, or I should say the pituitary gland gets separated from the hypothalamus. So pituitary stalk got injured. So now tell me, whenever this pituitary stalk got injured, what will happen? The hypophyseal portal blood vessels will be affected. So now I am asking you, do you think the hormones which are coming, the hormones which are producing from the hypothalamus, do you think they can reach the anterior pituitary? No, definitely not. So the stimulation, the releasing hormones which are coming from the hypothalamus, now they are not able to reach the anterior pituitary. So what will happen to the anterior pituitary hormones? What do you think will happen to the anterior pituitary hormones? So as usual, the anterior pituitary hormones will decrease because the stimulus is not coming from the hypothalamus. So that's the reason why the growth hormone, thyroid stimulating hormone, FSH, LH, ACTH, all these anterior pituitary hormones, they are decreasing. Now what will happen to the prolactin? If you see here, the prolactin is increasing. Why prolactin is increasing? Because the dopamine or the prolactin inhibitory hormone. Now do you think it can reach the anterior pituitary? No, it's not able to reach. The inhibition is not reaching the anterior pituitary, so the lactotropes are not getting inhibited. So that's the reason why prolactin is increasing. So all other anterior pituitary hormones will decrease except prolactin. Prolactin is going to increase. Okay. So imagine there is a female who had this road traffic accident. Okay. Now from tomorrow, what do you think will happen in this female? Because of this pituitary stalk injury, okay, the dopamine is not able to reach the anterior pituitary, and the lactotropes in the anterior pituitary, now they are not getting inhibited. So now they will release a prolactin, and the prolactin is going to release milk. The prolactin is responsible for the production of the milk. So from tomorrow, she is going to have the galacturia. Okay. So after accident, she is going to have the milk production. So when she usually should have the milk production after the delivery, but because of this accident, she is having the abnormal milk production called as galacturia. So the final summary is, whenever the anterior pituitary is separated from the hypothalamus due to damage to the pituitary stalk, all anterior pituitary hormones will decrease except prolactin. Okay, done. Next clinical case is called as the Sheehan syndrome. So what exactly is happening in the Sheehan syndrome, sir? Listen carefully. Imagine there is a pregnant female. Now in a pregnant female, the size of the pituitary gland, okay, the size of the pituitary gland will increase. Okay, in order to meet the demands, the size of the pituitary gland will be increased. There is hypertrophy of the pituitary gland, let's say. Now this pituitary gland is going to demand more blood. Okay, big size gland, so it demands more blood flow, it demands more oxygen. Okay, that's fine. So during pregnancy, the size of the pituitary gland will be big. Now what is happening? 39 weeks completed, term reached. Now she is delivering the baby. Now in this female, see, while delivering the baby, okay, she have delivered the baby also, a complication happened. So what exactly is this complication? She developed postpartum hemorrhage, which means she is having massive blood loss. Okay, she is having a massive hemorrhage, okay, after delivering the baby. Now the bleeding is not controlled. She is having a lot of bleeding, so that she is, let's say she is going into shock. Now tell me, what will happen to her blood volume? Okay, in this condition, what will happen to her blood volume? Definitely is going to be less. Okay. On one side, the mom's pituitary gland is asking for more blood. It's asking for more oxygen. But what happened? Now, because of the massive hemorrhage, the blood volume decreased. So in order to maintain her BP, okay, now she is in shock, right? In order to maintain her BP, the sympathetic nervous system is going to cause the vasoconstriction. So now, because of this vasoconstriction, what do you think will happen to the blood flow? The blood flow is going to be decreased. Okay, the blood flow to the skin decreases, the blood flow to the organs decreases. Also, the blood flow to the pituitary gland will decrease. On one side, pituitary gland is asking for more blood, more oxygen. But what is happening? Now there is ischemia. There is less blood flow to the pituitary gland, less oxygen supply to the pituitary gland. So what will happen? There is an insult. Okay. So first there is development of hypoxia. Oxygen is not getting delivered. Enough amount of oxygen is not getting delivered to the pituitary gland. So first initially there is ischemia leading to hypoxia. Okay, hypoxia. Now after some time, this hypoxia is continuing. So finally the gland will give up. Okay, finally the pituitary gland will give up. okay, and the pituitary gland is undergoing necrosis. So can I say something like this? Postpartum means after delivering the baby, there is a necrosis of the pituitary gland in this particular mother. Okay, so there is postpartum necrosis of the pituitary gland due to postpartum hemorrhage. As a result of the postpartum hemorrhage, there is massive blood loss. The patient went into the shock, which is going to cause a severe vasoconstriction. That severe vasoconstriction compromises the blood flow to the pituitary gland. Okay, compromise the blood flow to the pituitary gland, leading to ischemia and hypoxia and necrosis. So now you tell me, in this female, what happened to the pituitary gland? The entire pituitary gland is now dead. It's no more. So all the anterior pituitary hormones like growth hormone, TSH, FSH, LH, ACTH, even prolactin is decreasing. Why? Because lactotropes are also dead, right? Okay, lactotropes are also dead. So all the anterior pituitary hormones are going to go down, including prolactin. Now, as a prolactin is not available, now do you think she can be able to feed the baby? She is a mother, right? Okay, what's her main priority? Is to lactate and feed the baby. Now, what do you think? So, without having prolactin, do you ever think she is going to lactate? No, she is not going to lactate. So, there is failure to lactation. So, in Sheehan syndrome, there is failure to lactation. In pituitary stalk damage, there is unnecessary lactation, there is galactorrhea. But here in Sheehan syndrome, there is no prolactin and there is no lactation, there is failure to lactate. Okay. So, this is the second clinical case which I want you to know. Guys, now you tell me, when the pituitary gland is totally undergoing necrosis, there is no more pituitary gland, it's totally necrotized. Now, what do you see in the sella turcica? You know, pituitary gland is sitting in the sella turcica of the base sphenoid bone. Now, there is no more pituitary gland, so there will be empty sella. Okay, so there is empty sella. Okay, there is nothing sitting in the sella turcica. Okay, done. Now, let's see the third clinical case. Before going to the third clinical case, I want you to understand something. Look carefully, guys. Here is the hypothalamus, you know it. Okay, hypothalamus. Now, in the hypothalamus, the first nucleus, the arcuate nucleus. Now, this arcuate nucleus, what it is doing, it is releasing a hormone called as a GnRH, gonadotropin releasing hormone. See, this gonadotropin releasing hormone, how is it getting released? I have told you all the hypothalamic hormones are released in pulsatile doses. So, this gonadotropin releasing hormone is also released in pulsatile doses, means in regular intervals, not continuously, in regular intervals. Okay. Now, this GnRH, it is coming and stimulating which cells? Gonadotropes, it is stimulating the gonadotropes. Now, once the gonadotropes are stimulated, now the gonadotropes will start to release the gonadotropins. First FSH will be coming, later LH will be coming. Okay. This is normal. Now, imagine the same GnRH. What if the same GnRH is coming in a continuous doses? See, here you have to differentiate. Here I am showing in the dotted line, this is the pulsatile doses. Whenever the pulsatile doses of GnRH are coming, yeah, the gonadotropes are happy, the gonadotropes are activated, and the activated gonadotropes are going to release the gonadotropins like FSH and LH. What if you are using the GnRH in a continuous dose? Okay, continuous dose. Now, such continuous GnRH actually suppresses the gonadotropes. Okay, suppresses the activity of the gonadotrope. So, what do you think will happen to the FSH levels and LH levels? Actually, they will go down. Okay, so now it's the same GnRH. It can activate the gonadotropes or it can suppress the gonadotropes based on whether the GnRH is coming in pulsatile doses or continuous doses. Okay. Now, why you should know this concept as a doctor? Why you should know this is because, see, in the pharmaceutical industries we have manufactured drugs similar to GnRH like drugs. Okay, there is availability of the GnRH like drugs. What are the examples of such drugs? Okay, such drugs are available. GnRH like drugs or GnRH analogs are available. One such drug is nafrelin. Okay, nafrelin, goserelin, leuprolide. These are all GnRH analogs, GnRH like drugs. So now you tell me, you can use this GnRH analog either in pulsatile dose or either you can use it in continuous dose. Okay. Now, where will you use such pulsatile doses of GnRH, pulsatile doses of this nafrelin? Okay, where do you think you will use? If you are using it in pulsatile doses, what will happen? The gonadotropes are activated and there is release of FSH-LH. FSH-LH, what they will do? They will help in the production of estrogens, they will help in the follicular maturation, they will help in ovulation, okay, menstruation. So, such pulsatile doses of GnRH analogs like nafrelin is used in the treatment of which conditions? It is used in the treatment of delayed puberty. Delayed puberty. Now you tell me what exactly is delayed puberty. Imagine there is a female of 16 years. Okay, even after 16 years, she is not having breast development. She is not having the menstrual cycles. So she is little worried what happened with her. Okay, what is something wrong with her body? Okay, all her peers, okay, peer age group, they have gone into the menarche. Okay, they have gone into the puberty, but she is not having the puberty. So she is little worried. So how you have to treat her? You have to give her nafrolin. How? In pulsatile doses. When you give her nafrolin in pulsatile doses, the gonadotropes will be activated. There is going to be FSH release. FSH causes the follicular maturation. Once the follicles are getting matured, the granulosa cells of the follicles will start to produce the estrogen. Estrogen causes the breast development. Estrogen causes the endometrial proliferation. And LH is going to come. LH is going to cause the ovulation. Okay, she will come into her puberty. So for the treatment of delayed puberty, pulsatile doses are used. Then what about the continuous doses? Where you will use the continuous doses? So continuous doses are used for suppression of FSH and LH. Where do you use the continuous doses? Continuous doses can be used in the treatment of early puberty or precocious puberty. Okay, early puberty, also called as a precocious puberty. So imagine there is a female, there is a small girl of 8 years old. Now this 8 years old girl, now she had this breast development and menstrual cycles. I am asking you, do you want such a small girl to go through such painful process by 8 years of age? No, right? So her mother is worried and she was brought to the clinic by the mother. Now her mother is asking like, doctor, this is what happened with my daughter. So please help her. So what you have to use? You have to use the same nafrolin. Use the same nafrolin but in continuous doses. Because when you give the nafrolin in continuous doses, the gonadotropes are inhibited. So there is no concept of FSH and LH. Without FSH and LH, there is no breast development, there is no estrogen, there is no endometrial proliferation, there is no ovulation. So puberty ceases, puberty stops. Okay. So these two drugs can be used. Okay. So not two drugs, the same drug, nafrolin, it can be used in the treatment of either it can be used in the treatment of precocious puberty or delayed puberty. Okay. So with this, what we have completed? We have completed the 3 clinical cases. Now let's continue with the posterior pituitary in this video itself. Guys, now I am asking you, sir, posterior pituitary, it is producing which hormones? Usually students will say, sir, posterior pituitary is releasing hormones like antidiuretic hormone and oxytocin. But the answer is no. Posterior pituitary is not producing any hormones, it just only stores the hormone. Okay, it just stores the hormones, guys. Then where these antidiuretic hormone and oxytocin are getting produced? See, they are getting produced in the hypothalamus. See, in this diagram, in hypothalamus, you can see 2 nucleus. There is something called as the supraoptic nucleus and the paraventricular nucleus. The supraoptic nucleus and paraventricular nucleus, what they are doing, this is the place where they are synthesizing the antidiuretic hormone and oxytocin. And these hormones, with the help of the hypothalamo-hypophyseal portal tracts, they are reaching the posterior pituitary. And the hormones are getting stored here, that's it. Okay, they are temporarily getting stored there. Okay, this is not the place where the production is happening. So whenever there is a need, whenever there is a stimulus, so the posterior pituitary is going to release oxytocin or antidiuretic hormone. Okay. So how to remember this? See, the mnemonic that I use is SOAP. So the supraoptic nucleus is the one going to produce antidiuretic hormone and the paraventricular nucleus produces oxytocin, very important for your exams. Especially lot of times this question has been asked, supraoptic nucleus produces the antidiuretic hormone and the paraventricular nucleus produces the oxytocin. Now, what is the function of this antidiuretic hormone and oxytocin? See, first let's write oxytocin, you anyway know, produced from where? Produced from paraventricular nucleus. What are the functions of the oxytocin? See, there are 2 functions. The 2 functions of the oxytocin are labor, uterine contractions during labor. Okay, uterine contractions and milk ejection. Okay, milk ejection. So this was a recent question asked in the exam. In FMGE exam, this question was asked. They have shown a mother who is breastfeeding the baby, and they have asked a question something like, while breastfeeding. Okay, while breastfeeding, she is having cramps in her breast. Okay, she is having pain in her breast, and this pain is because of what? This pain is because of the oxytocin. Oxytocin is going to cause the contraction of the myoepithelial cells, and that's the one which is responsible for the pain and milk ejection. Okay, so oxytocin is the one responsible for the pain in the breast. Okay, during feeding. Next, so oxytocin is concerned with the uterine contractions during the time of delivery. Okay, helps in the delivering the baby. Next is oxytocin is released via neuroendocrine reflex. Now, we will be having a doubt, sir, what exactly is this neuroendocrine reflex? Let me explain you in this diagram. Everyone, look here. You know, the organ that I am showing you here is the uterus, let's say. Here is the uterus. Now, the baby is going to be there in the uterus for how many months? Let's say 9 months. The baby is going to be there for 9 months. Have you ever wondered why labor is going to happen? Okay, why these uterine contractions are going to happen exactly by 9 months of time? See, within this 9 months, what is happening? The baby's head size increases, right? The baby's head size, the circumference of the head is going to increase. So, when the 9th month reaches, the baby's head circumference is enough. Now, this baby's head, what it is doing? The baby's head is going to stretch the cervical wall. The baby's head, whatever is there, now it will start to stretch the cervical wall. Okay, the baby's head circumference is increasing, so it's going to stretch the cervical wall enough. Now, this is the stimulus. Now, from here, a neuron is going to take this information. Okay, the neuron is taking the information to the hypothalamus. The cervical wall is getting stretched. The baby is ready. 9 months completed. The cervical wall is getting stretched. So, this is the time to kick the baby out. Okay, deliver the baby. So, hypothalamus got the information. Now, from the hypothalamus, the information will go to the posterior pituitary, and the posterior pituitary, now it will release the oxytocin. Now, oxytocin is getting released. And you know, oxytocin, what it will do? Oxytocin is going to cause the contraction of the uterine smooth muscles. So, the baby will be delivered. Okay. So, now what I am trying to say, it's a cervical stretch, guys. It's going to give the signal to the hypothalamus with the help of the neuron. So, that's why the word neuro. See, with the help of the neuron, the information is going. With the help of the sensory neuron, the information is going. So, neuro. And in response, an endocrine hormone is being released. So, endocrine. So, neuroendocrine reflex. It's like a positive feedback reflex. So, what happened first? The cervical area, the cervix is getting stretched. So, that is going to release the oxytocin. Oxytocin, what it will do? It will cause a further contraction of the uterine muscles. So, there is further stretching of the cervix, right? When the baby is getting descended down, there is further stretching of the cervix. So, that will again give the stimulus. So, it's like a positive feedback loop. Okay. So, what I am trying to say at the end of the day, this oxytocin is released via which reflex? Neuroendocrine reflex. And what is the stimulus for the release of oxytocin? The stimulus for the release of oxytocin is cervical stretch. Now, let's look at here. So, baby is delivered, let's say. Now, what the baby is doing? See, the baby is latching up onto the nipple of the mother and the baby is sucking the nipple. Now, when the baby is sucking the nipple from the areolar area or from the nipple area, again the sensory information is going. Okay, again the sensory information is going to the hypothalamus. The baby is sucking the nipple, we have to release the milk. Now, again the information is going with the help of a neuron. So, the word neuro. Now, in response, who is again getting released? Oxytocin is getting released. Why oxytocin is getting released? Because oxytocin will help in the milk ejection. So, again, this is also an example of the neuroendocrine reflex. Now, tell me, what are the two conditions where oxytocin is getting released? Whenever the cervix is getting stretched, that is the stimulus for the release of oxytocin. And whenever the nipple is being sucked, whenever there is sucking of the nipple, that's also a stimulus for the release of oxytocin. Here it helps in the uterine contraction, here it helps in the milk ejection. So, right, what are the two examples of the neuroendocrine reflex? The two examples are cervical stretch causes the release of oxytocin, which helps in uterine contractions, and sucking nipple also releases oxytocin. That will help in milk ejection. Okay. So, these are the two examples of the neuroendocrine reflex. You might be thinking, why I am so keen, why I am so interested in this area is because, see, in one of the exam, in INICET exam, this question has been asked. See, they have asked something like this. The cervical stretch causing the uterine contractions is similar to which of the following? It is similar to sucking the nipple causing milk ejection, because both of them are examples of the neuroendocrine reflex and both the conditions, the hormone involved is oxytocin. Done. Next, apart from this, anything else that you have to know regarding the oxytocin? See, oxytocin, it is a drug of choice for, okay, where we will use the oxytocin in the clinics. Oxytocin is the drug of choice for the prevention and treatment. Prevention as well as the treatment of postpartum hemorrhage. Let's say You want to prevent the postpartum hemorrhage. Okay, the hormone that can be used is oxytocin. Or let's say the female is right now having the postpartum hemorrhage, she is bleeding out of her uterus, she is bleeding and she is going to shock. So how can we stop this bleeding? By giving the oxytocin. When you give oxytocin, uterus is going to contract. When the uterus is getting contracted, the bleeding will stop. So both for the prophylaxis as well as the treatment, the drug that we can use for the postpartum hemorrhage is oxytocin. Done. Next, let's see about vasopressin. See, vasopressin, also called as antidiuretic hormone, you already know. In the recent exams, the question was something like this: the antidiuretic hormone is going to act on which part of the nephron? Collecting duct. Which part of the collecting duct? Is it the cortical collecting duct or the medullary collecting duct? See, here there is a controversy, but the most common site for the action of the antidiuretic hormone is the last part of the nephron, that's the medullary collecting duct. Okay, some books mention cortical and some books mention medullary, but most of the books are saying that it's the medullary collecting duct which is the most common site for the action of the antidiuretic hormone. Okay, now let's say antidiuretic hormone, already I have taught you, produced from which nucleus? Supraoptic nucleus. So pneumonic, supraoptic nucleus. Antidiuretic hormone is going to act on which part of the nephron? Acts on collecting ducts. Collecting ducts. It acts on both cortical collecting duct as well as medullary collecting duct. Acts on both, but medullary collecting duct is considered to be the main action site. Okay, the last part of nephron which helps in major reabsorption of the water. Next, this antidiuretic hormone, when do you think it is going to be released? Or what is the stimulus for the release of the antidiuretic hormone? This is the question. See, what is the stimulus for the release of the oxytocin? It is the cervical stretch. Okay, it's a cervical stretch which is the stimulus for the release of oxytocin and sucking the nipple. And what is the stimulus for the release of this antidiuretic hormone? See, the stimulus is hypertonic plasma. Hypertonic plasma. It's not the hypotonic plasma, guys. I have seen in certain Q banks where it is given as a hypotonic plasma, but no, it's a hypertonic plasma. Hypertonic plasma, what exactly do I mean by hypertonic plasma? It's concentrated plasma. When do you think your plasma is getting concentrated? During dehydration. Okay, during fluid loss or blood loss or dehydration. Okay, so what I am trying to say, whenever you are getting dehydrated or whenever you are having fluid loss, or I can use the word hypotension also, because in one of the exams this was the question asked. Okay, what is the stimulus for the release of the antidiuretic hormone? The option was hypotension there. Hypotension means you are getting dehydrated, some form of blood loss or fluid loss is there. So hypotension. So now I am asking you, see, whenever you are losing the fluids out of the body, okay, either in the form of the sweating or either in the form of diarrhea or hemorrhage, what do you think will happen to your plasma? Your plasma will become diluted or concentrated? Your plasma will definitely become hypertonic. There is hyperosmolarity. So that hypertonic plasma is the major stimulus for the release of antidiuretic hormone. So this is the best answer. Okay, if this hypertonic plasma was not there, you can go with the other options like dehydration or hypotension. Okay, they are also correct answers. Okay, now simply I am asking you, you think logically and tell me, whenever a patient is having a dehydration or fluid loss, is that the good time to produce more urine? No, that's not a good time to produce urine, because already the patient is in dehydration. That's not a good time to lose the fluids out of the body. You have to conserve as much fluids as possible. How to conserve the fluids? Antidiuretic hormone. Antidiuretic hormone decreases the urine production, increases the water reabsorption, trying to maintain the fluid levels in the body. Okay, so with this what we have completed, successfully we have completed the two posterior pituitary hormones also, that is oxytocin as well as vasopressin. Hope the video is helpful. Thank you.